Hi,
Hi.
good evening, everybody. Welcome to another session of Beating Hearts webinar. Today, Dr. Roshan is going to speak to us on how to identify fractures on X-rays. Dr. Roshan, of course, you may know him because he has presented a webinar before on trauma a few months ago,
Months
maybe.
ago now, yeah.
Yeah, that's right. And welcome back. As you can see, we have grown quite a lot. The attendance is and the response has been amazing.
Right.
So Dr. Roshan is a consultant surgeon with Subang Jaya Medical Center. He is actually trained pediatric orthopedic surgeon. But today he's going to just on how to identify X-rays. Go ahead.
All right. Good evening, everyone, and thank you for the introduction, Dr. Betty. So yeah, I'm currently working in Subang Medical, orthopedic surgeon there. I was given this topic, how to identify fractures on X-rays. So how this is going to go, we have the overview of what we're going to do, introduction, some of the common ground rules, a systematic approach to actually looking at X-rays, how to describe the fracture patterns, and just touch a little bit on some of the special X-rays, variations on certain conditions that you may come across in practice one day. And the last part, I just put interpretation of healing of fractures because my talk was too short anyway. And so I thought I'll add on an extra bit to tell you all a little bit on how to identify if a fracture is healing on an X-ray. Okay, so it's not as, to me, it's not, I find reading ECGs a lot more complex. So anyway, this just generally an X-ray. So how do you identify a fracture on this? Okay, strangely enough, this is from a calendar for radiologists, would you believe? You know, so I don't know, radiologists, yeah, radiologists are strange people. So, okay, I mean, so, okay. All right, this is not what it is. All right, so this is a common X-ray. Okay. Okay, so this is a femur X-ray. X-ray of the left femur. It can shows you the hip joint, and this shows the femur which is fractured. Okay. So currently you have identified a fracture on X-ray, and that is pretty much the talk for today. All right, thank you.
This is quite straightforward. This one, I think I can identify a fracture.
Yeah. Okay, so just to make it basic, yeah, I think the main aim here is actually to, since I assume most of the participants are junior doctors or those who are just starting off orthopedics and whatnot, or even in other specialties, but you may have to deal with fractures. So I think the important thing is to know how to present the X-ray to somebody else. It's no point just saying I have a patient with a fracture and you know, you don't actually explain it properly to the person. Those who are doing orthopedic postings, and if your boss or your MO or your specialist is a little bit more old school, you might end up getting a lot of into a lot of trouble if you don't present properly or explain properly what it is you're talking about. And a lot of times nowadays we communicate over the phone. You want to refer a case to another hospital, or you want to refer the case to your senior colleague. You need to describe it correctly because management can be different. The urgency of fractures can be different. So if you present it like crap, then we're going to end up, you know, doing the wrong thing and managing the patient wrongly. All right, so just a quick one. This is just an introduction of what is an X-ray. It's an electromagnetic wave of high energy and short wavelength, very short wavelength, which can pass through materials opaque to light. And it forms an image. And as you all know, the composition of the image produced by the X-rays. It's absorbed at different rates for different materials. All it means is something more solid will appear white, something gaseous will appear black. All right, and that is just definition of an X-ray. Definition of a fracture. What is a fracture? Actually, it's a break in the continuity of a bone, and it's always associated with certain amount of soft tissue injury. The current definition is slightly different, but it also has the two important components, which is soft tissue injury plus a break in the continuity of the bone. Okay, but are X-rays the way to identify fractures in a general practice? In practice, I mean. Yes and no, actually. Okay, why is that? Oh, this is just a few more radiology humors. I don't know. Okay, yeah, this never really came to fruition as much as I wish it did. The X-ray goggles never really came, and we don't really use it in hospitals, so don't worry. Okay. Anyway, so okay, so when it comes to identifying fractures, yes, it is also very, very important to actually take a good history and a physical examination before you go into looking at an X-ray. Always don't make the mistake of trying to diagnose something straight off from an X-ray without examining the patient first. All right. Of course, there are other investigative modalities that are available now. You have CT scans, MRIs, and various other imaging that can be done. But there are certain centers in Malaysia which do not have that facility. If you're in a rural hospital and whatnot, you may only be stuck with an X-ray. So you may need to learn how to read it properly and to interpret whatever you read properly. So the X-ray is generally used to give you a provisional diagnosis, and the provisional diagnosis is given by your physical examination and your history, and the X-ray actually confirms what you think it is. So don't rely 100% on X-rays, yeah, because sometimes, especially now, people send X-ray over the phone and asking your boss, what do you think about this and that, and then on WhatsApp and all that. And things can easily go wrong. Things can be missed. Fractures can be missed, wrongly identified. A lot of things can go wrong. So just be very, very careful when you're dealing with X-rays. The reason being is the lawyers are onto us. Okay, so the lawyers kind of know that a lot of mistakes are being made when it comes to reading X-rays. And so they quite target those who are junior and make mistakes, and very easily, government and whatnot are getting sued for it. So just be a little bit wary when you're reading X-rays. It's a medical legal document after all. All right, for X-ray protection depends on the thickness of the tissue that is penetrated. When there's no tissue, the color will be black, obviously. A simple guide, air is projected as black. If you have soft tissue, it's kind of gray. Fluids are lighter gray. Bone is even lighter gray. And metal, as you can see in this image here, the metal implant is actually projected as white. Okay, so this just sounds like a lot of different shades of gray. But that's generally what an X-ray is. It's not just black and white, as you hope. All right, when you're reading an X-ray, there's always the rule of two to remember, okay? So you have two views, commonly AP and lateral. You have two joints. You have to visualize the joint above the fracture and the joint below the fracture. Sometimes you need to do the X-ray on two occasions. If you cannot identify it correctly on the first, you take it at a later date to see if there's any evidence of callus or if there's any healing or any change compared to the first X-ray. And sometimes you need to take two sides, and that is to compare the contralateral limb. And this is commonly used in pediatric orthopedics because sometimes in children, the X-rays are even more difficult to interpret and to identify. And if you're not sure, you tend to compare, you take an X-ray of the opposite limb as well, right? So this is generally the rule of two when you're reading X-rays. Okay, so mandatory again to take two views, AP and lateral. Why is that? Because you can easily miss things or interpret them wrong if you look at it from just one view. Okay, so this is a clear example. If you didn't take the other view, you would think something completely different. All right, and it also happens in actual orthopedics as well. If you look at if you're just taking a lateral view, you don't really get a good idea where the fracture is. Whereas if you take an AP view, you can see there's a nice spiral fracture over there. So it's always mandatory to take two views in any X-ray, at least two views. Adjacent joints, it's important to take the joint above and below, or joint proximal and joint distal. So if you see this X-ray, what is the most obvious? Most people would say is there's a fracture of the. I can't ask anyone questions, can I? It's fracture of the ulna.
Oh, can. Right? Okay, yeah. You can.
Oh no, they can't answer me immediately. So
no, they can. Oh, we have been doing it quite well. What you do is you ask them a question and they will all type in the chat.
Alamak, I have to read it. Okay, anyway.
Yes, I will read it. I will read it.
All right. Okay. No, anyway, it's not okay. I'll explain this anyway. Okay. So the reason why you take two X-rays is when you look at this, you can notice there's obvious break in the shaft of the ulna. But if you didn't take an X-ray of the joint above, which is the elbow, you actually won't notice that the radial head is actually dislocated here. Okay, so this is the radial head. It's supposed to sit somewhere inside here. Okay, so it's supposed to be here, but it's gone upwards. So if you just taken one X-ray here and you miss the other side, you won't really see it. So that's always important to take the joint above and the joint below any fracture. Okay, two different occasions. Why? Because sometimes you cannot identify the fracture on the first view. You repeat it about 7 to 10 days later, and you might notice, such as this case, where there's callus formation over the clavicle. Yeah. Again, commonly in children, where sometimes the X-rays are not easy, it's a very subtle sort of a fracture. You may not actually see it on the first, but on the second film, you might see some callus, you might see reduction in soft tissue swelling, etc. Okay. Sometimes, again, as I said, in pediatric ortho, you tend to take the opposite limb just because you're not sure what you're reading on one side. So the reason is in immature skeleton or pediatric bone, there are a lot of cartilages and ossification centers like shown in this picture. Yeah. So most of the bones look something like this. This is an X-ray of the foot in somewhat of a newborn, I would say. You can't identify any of the tarsal bones or any of the bones. It's just a little dot in the middle. So if there is an injury or a fracture, you'll never be able to identify it on an X-ray. Okay, so if you have subtle changes in the bone, it's good to compare to the opposite side. Okay, so when it comes to reading X-rays, it's easy to miss things, but I think the idea is to have a systematic approach to it. Okay, if you follow, in your head, sort of a step-by-step what I'm looking for, you will actually get what you're looking for, right? It's not as difficult as it may be for some at the moment. If you just look at it and you try to give all the information one shot, you may not get it. But if you follow, just subsets of what you're looking for, you'll actually find it. All right. Always start with the name of the patient. Sometimes date of birth if it's printed on the film as well. Okay. Very, very important, because this has happened to me, to many other orthopedic surgeons, especially back in the day when there wasn't digital films and most of the X-rays were printed out on put it on that machine and have a look at it. There have been times where other people's X-rays have come into this patient's file, and you tend to read the wrong X-ray about the wrong patient and schedule them for different operations that they're not supposedly going for. Okay, so it has happened. It's not unheard of. There have been cases where people have tried to operate on things that actually wasn't even broken because we read the wrong X-rays. Yeah. So always look at the name and the date of birth if it's there, but name very, very important for the patient. Okay. And the date the X-ray was taken as well. Okay. Please identify this is not an X-ray taken 20 years ago and you're looking at it for the same patient. All right. And identify the side of the body, because if it's left or right, also very, very important. Okay. You cannot schedule surgery for the wrong side and mark the wrong thing and mess things up. Okay. Very simple. These are the things you actually look for in an X-ray: the location of the fracture, the pattern of the fracture, the alignment, and what most people forget eventually, the soft tissue component of the fracture. Okay, so location of fracture. Okay, this may seem a bit, insulting your intelligence for most doctors. You kind of know all these bones, lah. These are the simple ones. Okay, but you try not to get this wrong, because to be honest, I have been people have tried to refer to me cases saying all the wrong bone and the wrong name for it and everything. Even big things like some time ago, there was someone referred a case for multiple finger fractures, and all the fractures were in the foot. Okay, so you don't have fingers in the foot, and seriously, so try to get your anatomy straight if you're going to present to anyone. If you're nervous, just calm down before you present, I suppose. Okay, but get an idea of where the bones are and what the bones are called at least. Okay, and then each long bone, as it is, has different segments. They have a proximal, a middle, or a distal and the distal segment, called the epiphysis if it's a kid, the metaphyseal region, and the diaphysis. So these are words that can be used in the description of an X-ray. And it gives whoever you're presenting a clear idea, even without looking at the X-ray. Just over the phone, you can tell me as a mid-shaft, or there's a diaphyseal fracture of the femur. So I know exactly where it is. Okay, so the location is very, very important then. Okay, so these are where some of the common names used. Diaphyseal, center of the bone. Metaphyseal is towards the end of the bones, but not at the joint. Periarticular is the bone just adjacent to the joint. Intraarticular are generally fractures that extend into the joint. And proximal distal, I think most people know. Proximal is something superior or closer to the center of the body and upper end of the bone. Distal is the more further away it is. Yeah. So these are words that I actually use to describe fractures, and it gives us actually a very, very clear idea where the fracture is, and also it has a bearing on the type of management that will be needed, because fractures at the diaphyseal region and fractures at intra-articular region will have different management by the end of the day. Yeah. Okay. Fracture patterns, we're looking at long bone sort of patterns. They're obviously flat bones and as well, like spine and all, but we'll just look at the long bone for this. So these are the common patterns that you get in a fracture. Okay, transverse, linear, very, very rare. Oblique, which is displacement. Spiral fracture, green stick happens in only children, and comminuted type of fractures. What this actually shows, right, If you have a different pattern of fracture, it actually indicates a different mechanism of injury. Okay, so if you fall directly on your leg, the fracture will be different. If you have a bending force applied to your leg, the fracture will be different. If you have a twisting force applied to your leg or your limb, the fracture will be different. So if someone comes in with a spiral fracture, you tend to know that they twisted their limb somehow. You know, it's not a direct impact by getting hit by a stick or anything. It's definitely some sort of force and twisting force. And that causes a spiral fracture. Okay. And this is important to identify in children when they come in with spiral fractures, because they don't normally fracture this way. And if there is a spiral fracture, you have to sort of be aware of non-accidental injuries as well. Yeah. So the fracture pattern sort of gives you a clue as to how the patient fell. Okay. So far, okay, I hope.
Yeah, so far so good.
All right.
Very interesting.
All right. Okay. The next thing to look for is the alignment. Okay. Very simply, is it displaced or is it not displaced? That would be the easiest. Okay. Undisplaced fracture means there's a fracture line, but both the fragments are perfectly aligned to each other. That's undisplaced or non-displaced. Okay. Minimally displaced when there's a slight shift in the position. Completely displaced, this is a different story altogether. Depressed is just a way of describing fractures of the joint, where part of the joint is actually compressed downwards. And then you also have others like angulation of long bone fractures, sometimes causing shortening. Because just to note, right, if you have a long bone fracture, like you have a radius and ulnar fracture in an adult, what happens is you will notice that the bones are not always intact. They tend to be displaced, right? And that usually happens because of the muscle pull due to the bone attachment of the muscle to the bone. Due to the muscle pull, once the fracture occurs, the fragments are pulled apart by the muscle. So if you have no muscles, generally it will be straight. Okay, and sometimes you can get a shortening effect because the muscles pulls the bone and there's an overlap of the two fragments. So you call it a shortening. Okay, it's an effect that usually if you once treated, it shouldn't be there. Okay, and the other thing is soft tissue component. When you're looking at the X-rays, every fracture always has a soft tissue swelling. And it's something to look out for on X-rays. Okay, none of this actually came out nicely on the slide, so I can't really show you much here. But if you do see an X-ray, always look around the bone, because there will be a certain amount of gray area surrounding the bone, which indicates the amount of soft tissue swelling. Okay, and that is also something to comment on when you're reading an X-ray. Okay, so what I normally do, okay, it's just step by step what I do. Again, first identify the name and ID of the patient and that the X-rays correspond to the name. As I mentioned earlier, mistakes have happened. Okay, identify the limb. Which part of the limb is it? The femur, the tibia, the radius? Please know at least the major bones where they are. The side of the fracture, whether it's right or left. Is the film adequate? Okay, and this follows the rule of two. Do you have an AP and lateral view? Do you have the joint above, the joint below? Visualize on your X-ray film. And identify. What I normally do is once I've come number 1 to number 4, these are all very basic. Yeah? So if you're presenting in an exam, right, number 1 to number 4 shouldn't require much brain power. Okay, it's just basically what is on the X-ray. You're just reading it out. And at the same time, you're trying to think, okay, how do I con the examiner for the next subsequent steps for it? All right. So 1 to 4 is very, very basic. Okay. So once I've completed my 1 to 4, then I think about, okay, what is the most obvious thing on this film? All right. It doesn't matter. Some people, you know, like the first X-ray I showed of the femur fracture, it was very obvious. The first thing you see is a break in the mid shaft of the break in the femur. That's pretty much it, a femur fracture. All right. So is it a fracture? Do you see any displacement, or is there a foreign body that you notice, or is there something abnormal within the bone itself? Okay. So always identify the most obvious thing first. And then you start to describe the film. So there are 2 ways of doing it. You can describe inside out or outside in. All right. Basically means if I start inside out, I start describing the bone first, and then I move outwards towards the soft tissue and the skin and whatnot. And I just describe what I see. All right. Some people, number 7, these are the KASU students who will get the extra mark and the star, and you know, because they tend to say that the X-ray film is well penetrated and clarity and angle and all that. But number 7, not so important in orthopedic surgeon. And also nowadays, it's all digitalized most of the time. If you sit for exams, they give you digital films. You don't really need to comment on the adequacy of the firm. Yeah, but currently, if you take X-rays outside, sometimes even the firm, the printed sheet X-rays, you do get poor quality X-rays, over penetrated, under penetrated, and it obscures your view. And you should actually try to get a clear X-ray before coming up with a diagnosis. Yeah. Okay. So example one, very simple. So first thing you do, get the patient's name, get the date the X-ray was taken. Okay. None of these come out on Google's and whatnot, because I think it's patient's privacy. I can't put patient's name on these slides. Yeah. But every X-ray will have the patient's name printed on it and the date the X-ray was taken. So always identify that first. So if I'm going to look at this X-ray, I'm going to say it's the left humerus. Okay. It's only an AP view. I don't see any lateral view in this film. Okay. I'm able to visualize the shoulder and the elbow joint. So the shoulder joint is up here and the elbow joint down here. So one joint above, one joint below. But the film is inadequate because it's only a AP view. There's no lateral view here. What I noticed, the obvious thing I noticed, the most obvious thing, there's a fracture at the distal third of the humerus. Okay. If I want to describe it, I describe it as a spiral fracture. It has a mild displacement. It's sort of translated a little bit to the side. Translation means movement to the side. There's not that much angulation. It's fairly straight. Okay, it's extra articular, meaning it's not involving any of the joints. The joints are very, very far away. Elbow joint is here, humerus, shoulder joint is way up there. So this is an extra articular fracture, nowhere near the joint. Okay, and there is soft tissue swelling. May not come out too well on the slides, but there is some soft tissue swelling on either side of the fracture. All right, so that is basically a simple fracture and how you would present it to somebody in a sort of a more comprehensive way. Basically, there's nothing more than that you have to present when you're reading an X-ray. Okay, very, very simple. So I got a few other examples. Okay, so this is, so I go through them myself here.
No, ask them. Okay.
Maybe
yes.
one person. How do I see that?
Can you describe the fracture, please? Let's see. Anyone?
Give you 2 minutes.
Yes, can. Come on, guys.
Yeah.
The last two webinars, we have had a very interactive session actually.
All right. Okay.
Okay. So no, Atika said left mid shaft femur fracture.
Where do I see her answer?
You go under the chat. It's at the bottom. Okay. So, okay.
Oh, I think because I'm sharing screen, I can't see.
No, can. Non-union left mid shaft femur fracture. Non-union.
Okay.
Okay. Lim Taiping said, oh, now it's coming too fast.
We'll take the first three guys.
Okay. Lim Taiping said there's a fracture from Mr. ABC dated XYZ. This is a left mid shaft comminuted fracture.
Okay.
Okay. Closed mid shaft.
Okay.
Comminuted. And then Serena said fracture of the left femur. Comminuted, displaced, angulated.
Right.
NRSH said left mid shaft of femur comminuted fracture. Okay, most say the same thing.
Same thing, ma. Okay.
And then the presence of soft tissue swelling.
Okay. You're almost right, except it's not really an open fracture. You can't really diagnose open fracture on
no, nobody said open fracture.
Oh, yeah. Okay. All right.
They said comminuted.
Comminuted is multiple pieces. Many pieces.
Okay.
Yeah. Okay, so this is a little bit vague. It can be comminuted, and someone said non-union because it looks like there's callus formation. So it doesn't look like a new fracture.
So clever.
Yeah, so someone was actually right. There's some sort of callus formation there.
Oh, the guy is so clever. Let me get his name. Yeah. So the guy's name who said non-union is Muhammad Hafizul Arif. Well done.
Okay, so it looks like that. Anyway, this is just a Google image. Sorry, I'm going too fast. This is just a Google image of that. But the main thing to understand is actually a step-by-step thing. Okay, date, name of patient, date. What is which side are we looking at? Do we have the adequate firms? Do we have AP and lateral? Can we see the joint above, joint below? then start to comment on what it is. Okay, yeah, the final answer not so important, but it's great that you identified something there. Okay. All right.
So the first fracture, sorry, the previous picture. So the first picture doesn't
This
show
one.
both joints above and joint
Exactly.
below.
So this one, you can only see the AP view, whereas the lateral view is not seen. So it's
No,
inadequate.
the next one, the next one.
Next one actually shows both. So
No,
this is the AP view on the left. This is the lateral view.
Yes.
Okay, and this is actually taken because they cannot fit the knee joint into
Oh,
the
I
picture.
see,
So they've
I
sort
see,
of
okay.
taken it on a different film.
I see.
It should be in one long film, but sometimes it happens in femur especially. All right. Okay, next one we can try.
Okay, what's the next X-ray? What's the fracture? Okay, they're typing. Damn
All
time.
right. Oh, yeah, I keep moving the temp.
Okay, can you mute? Okay, Ethan say,
Ethan, it is the leg, thank you.
Ethan said, let me see. So mid-shaft tibia and fibula fracture displaced by minutia. Serena said mid-shaft comminuted and angulated.
Correct,
Me,
okay.
Ethan said, okay, I can't.
No, Ethan said whether it's the hand or the leg, but it's actually the leg.
Oh my God, Ethan. Ethan, I'm so disappointed.
No, that's okay.
Okay, so
Okay, that's very good.
Monisha
Monisha
said
said
inadequate. Okay,
Excellent.
view
Okay,
unable
because you
to
cannot
view.
see. You
Yes.
cannot see the knee joint, yeah? You can only see the ankle joint. So a very good pickup there. Yeah, so it's a mid shaft, it's transverse, it's slightly oblique, the fracture, comminuted. There is angulation of both the bones, the distal, the fibula and the tibia. And this is what I meant about the shortening. You notice the fibula looks
Okay.
looks shorter. It's not really a shorter bone. It just looks shorter because there's an overlap there, yeah? Because of the tibia angulation, this fella has overlap there. So just to get the hang of this, basically that's correct. Most people got it right, yeah? I think I got one more.
Roshan, sorry, Roshan. We also have about 100 over people watching from Facebook Live. So I will also check the message there. Okay, go on, go on.
But anyway, this is just a practice, simple ones.
Yes,
so,
that's right.
One more. Anybody?
One more. Okay, one more.
Oh, I think
this one
I got
is
two more.
difficult one.
Yeah.
This one
This is very common fracture, by the way. So you will
I see the fracture. Okay. Oh, somebody say it's
Colles fracture. Fail.
Colles fracture. Fail.
The answer is correct, but the idea is how to read the X-ray, not give a diagnosis immediately. So that's what I was trying to avoid. I don't really want to tell.
So Monisha said fracture right radius, ulna, distal end.
Yeah, so that's correct. It's distal end. So the thing to ask yourself, when it is so distal, is it intra-articular or extra-articular fracture? Is it involves the joint or is it outside the joint?
Ethan said dorsally displaced fracture of the right radius at the distal end. Intra-articular. A lot of people say intra-articular.
Intra-articular, but actually it's not. It's extra-articular. The articular surface is not involved in it so much. The fracture, this is the articular surface, whereas the fracture is actually further down here. Yeah, it's actually, you're right. It is a Colles fracture. That's a diagnosis though. So when you read the X-ray, you cannot come up to me and say, "Oh, I got a Colles fracture." Okay, it makes no sense. So you have to go step by step and practice describing the fracture. And the diagnosis is correct. It is a Colles fracture, but that's not what most people want to hear immediately. Especially if you're training for masters and all that, you should learn how to describe it.
And it's very important. Always make a description in your mind before you read the X-ray report.
Yeah, you may have got it right. The answer is correct. It's Colles and whatnot. That's fine. But you're gonna get no marks for just saying Colles fracture. You get the marks by describing it more. Yeah. That's just to practice, and I'm sure most of y'all will see a lot of X-rays on daily basis anyway.
Shortening of the ulna. Serena asked whether there's shortening of the ulna.
No. There's no shortening of the ulna. The ulna is actually there. The radius looks like it's dropped down a little bit. The radial height usually, this part should actually be somewhere up here. It's dropped down. So it's no shortening.
Okay. No article asked whether it's volar dislocation of the ulna.
So volar, no, you describe the dorsal fragment here of the radius which is fractured. So I'm sorry, the distal fragment of the radius, which is displaced this way, which is dorsally. So it's a dorsal angulation of the radius. Relative to that, the ulna looks like it's volar, obviously. Yeah. Okay, so this one?
Okay, this
Last
one.
one.
Half one.
I think last one. Where was it? Okay. Nobody dared to guess already. Yes, get them away.
No, they're taking some time to type.
Okay.
Okay, so Atika said volar dislocation of ulnar left distal third fibular fracture.
Okay.
He said left close angulated fracture of the tibia. Shamini said distal third fibular fracture. Oh, too many people coming in already.
Yeah. So I should put the answer. Someone put distal and femur. The fellow should be shot.
Okay, there's Serena. Serena, don't say Serena,
There's a
please.
tibia. It's not the femur. Okay, very good. Someone said medial malleolus finally. Okay, so it is, yeah. So this is actually an
Somebody
ankle
said
fracture.
lateral malleolus also. Okay, go on.
Lateral is here. Okay, so it is actually an ankle fracture. The medial malleolus is here, and this is the fragment, yeah, that is well displaced. There's also a fibular fracture at the distal third. Okay, the ankle joint is incongruent now. Okay, so it's an intra-articular fracture. All right, there's some soft tissue swelling going on, not as much as I would have thought, but it doesn't come out so well here. The other thing is it's not adequate because we only have an AP view and we don't have any more proximal views of the tibia as well. Yeah, it's only one. We only have the AP view. We do not have the lateral view. Sorry. Okay.
Is this medial malleolus fracture an avulsion?
No, not necessarily. Because when you have a double fracture, it will not really be an avulsion. Yeah. It does not just pull out and cause a fracture here. If it is significant, only this without the fibula, then you can call it an avulsion. Okay, and that avulsion or not depends on the mechanism of injury for this patient. Okay, I see that someone said femur was a typo, so you're forgiven. It's okay.
You shot her and she's dead. You can't forgive a dead person.
That's
Okay,
fine.
go on.
That happens, lah. I'm just kidding. Anyway, this is just for practice purpose. You're not sitting for any exam with me anyway. Oh, there's another one. I don't know why I put this. Okay. Oh, yeah, I know why I put this. Okay, let's see who can get this. This one star student only will get.
Okay, come on. Star student, we have a lot of star
without
students.
The typos.
Without the typos. Come on, it's always the same people. We have 100 people. Okay, we have
the rest put the Zoom on and went off somewhere.
Balki said spiral distal third tibia fracture.
Okay, very good. Now some more spiral fracture, lower third, excellent.
Yes,
plastic. Okay, someone is getting very close. W, you're very, very good. You said there's a plastic deformation of the right fibula. There's a slight bend in the fibula, which is very, very good that you picked it up.
Wow.
Okay, so whoever W is, well done. Okay, so the point I'm making is, if you look at this X-ray, again, we go step by step, okay? Again, patient's name, date, whatever. This is a fracture of the tibia. We're not even sure left or right because it's not labeled there. Okay, so this is probably the right side. Assume it's the right. Inadequate because there's only an AP view, there's no lateral view, and we can't really visualize the knee joint. But there's an obvious spiral fracture at the distal third or mid shaft of the distal third of the tibia. When you do mention something like plastic deformation, what you're trying to say is there's also a growth plate here. Okay, this line is actually a growth plate or the physis, which means this is a pediatric fracture. Okay, this is not an adult. So you identified it as a pediatric fracture. You sort of hit it when you said there's a plastic deformation there. I don't know whether there was a luck or what, but anyway.
No, luck cannot be luck. He's smart. Okay, he's smart.
Very good. Okay, that's a good call. Okay, so what you need to mention as well is there is a growth plate present. So this is an immature skeleton or a child. Okay, it's a fracture in a pediatric population. It's not an adult fracture. Okay, so that most people will just go with this and forget about looking elsewhere. But if you notice, there's a growth plate, and very, very good that you actually picked up. There's a slight bend in that as well.
Well
okay.
done.
All right, I think now, okay. All right, okay, we're done with the examples.
Okay.
This is just to show that X-rays are not just AP and lateral. Some of certain conditions you will need special views. Shoulder dislocations, sometimes you look for injuries to the labrum, to the glenoid fossa. So you do different views known as West Point view, striker view. So these are taken differently. Yeah, it's taken something like this on the X-ray table, and all this currently is being phased out because most people, once you have, they go for MRI or they go for CT scan, and you don't need all this. So this is a bit pretty much historical value a little bit now, unless you're in a center that doesn't have any of these facilities. Again, if you don't have these facilities, you're generally not going to have a shoulder arthroscopy surgeon as well anyway. But if you don't, these X-rays still play an important role if you know how to read them. Okay, so these are special views you take for certain conditions. The second one is pelvic injury. Sometimes you can't just take an AP and lateral because the pelvic bone in the body is tilted. Yeah, based on the anatomy, it's not exactly horizontal to anything. So you have inlet and outlet views to identify any fractures that may occur in pelvic injuries. Spondylolysis is actually in the spine, which is a fracture of the pars or the connection. They call it the pars interarticularis. Okay, so this you normally take oblique X-ray views to see. And I still kind of use this X-ray sometimes when patients, especially young patients, come in with back pain after some sort of a sports injury and whatnot. You want to tend to have a look at the oblique view. You don't just go straight for a CT scan and radiate the patient to death. Yeah. Another one, again, pediatric bones, slightly different because they have, this is actually a normal development of the bone. As you can see, as they get older, it changes, the view of the X-ray completely changes. Okay, the cartilage is slowly becoming more solid bone. So as such, from 6 months old to much older, the bone, this is the bone of the same person and it's normal, but it's more difficult to identify at times. So you have to realize that pediatric bone, you need a little bit more practice sometimes to identify. You can't get this and suddenly call and say, oh my God, there's a fracture here. It's not, it's actually the growth plate, yeah? Okay, just to reiterate that fact that you have things like the epiphysis and the growth plate, the physis, and different regions in the bone. So growing bone and adult bone is different, okay? This one here, there's actually a fracture. This is known as a torus fracture or buccal fracture in the distal radius of a child. So these type of fractures technically only occur in children in the skeletally immature. Yeah, so just to keep in mind, when you have a child and you're taking an X-ray, just pay a little bit more attention to little subtle changes that may be there that won't be there in an adult. Okay, the fracture patterns are different, the bones look different. If you are in doubt and you have a pediatric, you have a child with a suspected fracture and you really don't know what on earth you're looking at in the X-ray, what do you think you should do? Actually, you should go by your clinical examination. Okay, patient has a history of a fall or injury. Physical examination shows that there's pain, swelling in that specific area, and X-ray, you have no idea what you're looking at. Always treat it as a fracture. Okay, most likely there's a fracture there. It's always better to over-treat these patients in that sense. Okay, in this sense, what I mean is over-treating, meaning don't send them for operation or anything, but at least you immobilize with a cast or a back slab or something. All right, so that will usually help.
Roshan, we have a question. Dhamma asked whether it's a green stick fracture.
Okay, no. So this is actually not a green stick fracture. Okay, there are two types of fractures that occur in pediatric ortho. So not only two, but these are the two types that occur. Okay, this is known as a buccal or torus fracture. Okay, the difference is the mechanism of injury. A buccal fracture such as this is usually due to a purely axial loading. Okay, that means direct fall, purely axial load in one direction. A green stick fracture is an axial load with a little bit of a twisting injury as well. Okay, so you get a slightly different looking X-ray. What happens is you have a break in one of the cortex, whereas the other cortex will be intact. That's a green stick fracture. In a buccal fracture, basically it's just like compressed down and this fella is like, buckled down like that. Yeah, you can see it just bulges out on both sides. Okay, that is a buccal fracture. Green stick, you will see a crack in one side.
So this buccal, is it torus fracture the same?
No. Okay, so not to get confused, someone is asking about Salter-Harris type 5.
That's
Mr.
right.
W.
And then another person is asking the mechanism of torus fracture.
Yeah, so torus fracture mechanism is a direct axial load. Okay, that means falling on outstretched hand, the force is directly 90 degrees like that. Okay, green stick is like that and a twisting.
Okay. Buckle?
Okay. Buckle is just direct impact without the twist.
So torus and buckle not the same.
No, torus and buckle is the same thing. Torus and green
Okay.
stick is different, sorry.
Okay, okay.
Green stick has a twisting effect. Torus does not have a twisting effect.
Okay. Is
Okay.
torus fracture same with Salter-Harris type 5 fracture?
Okay, so that is not. Okay, so this buckle fracture is, okay, first thing to understand, Salter-Harris fractures are a description of fractures involving the growth plate or the physis. Okay, so Salter-Harris fractures always happen at the growth plate. Okay, anything away from the growth plate, you cannot classify as Salter-Harris. Okay, so Salter-Harris is a classification of physeal fractures or growth plate fractures, which occur here. This one is far, far, far away. So this is not a Salter-Harris at all. Okay, Salter-Harris 5 generally is a buckle fracture. Is what you call a compression type of fracture. The mechanism is the same, but it occurs at the growth plate. It doesn't occur at the shaft. Okay.
Huawei, the telephone asked, how about the step to describe child fracture? Is 1 to 4? Is 1 to 4
yeah,
is pretty much the same?
Okay. The steps to describe a fracture.
Oh, I see. Okay.
The steps to describe a fracture, whether in an adult or a child, is exactly the same. You still go by the same step by step how you do it. Okay, there's no difference. The child, you just add on the fact that it's an immature bone because you have a growth plate, or you have a different type of fracture. That's about it. But the step by step part, don't forget to describe whether it's adequate, whether it's epilateral, whether the soft tissue, the swelling, everything there will be the same.
Okay.
All right. Okay. All right. Okay, this is just the last part on fracture healing. So most people past medical school would generally have had to read about this and then forget about it after the exams. But generally, fracture healing is a biological continuum. Okay, so it's an ongoing process. Once the fracture occurs, healing starts. Okay, and there are three main phases: the inflammatory phase, the repair phase, and the remodeling phase. Okay, I won't bore you with the details of it. This is generally just bedtime reading for most people before exam, how it heals. Just to highlight that it can happen, the timing of which these things happen. Within 48 hours, you get the inflammatory response. Within 14 days, you actually get soft callus or softer bone. And usually within 12 to 16 weeks, you tend to get a full healing bone. Okay, we're talking about long bones in adults, okay? And eventually the phase of remodeling happens where it restores the normal cortical structure. So it's generally three phases in bone healing. So why is that important is that usually when a fracture occurs, you follow up patients after that. And the best way to see how well the healing is going is to identify it on an X-ray. Okay, this is a diagram of showing you the fractures. Okay, so initially hematoma formation, fibrocartilage and callus formation happens after that. Then the bony callus forms, and finally you get remodeling of the cortical surfaces. This goes on, this is the process of bone healing. But this is what it looks like on an X-ray, okay? Early stages, you can see the fracture line, okay? It's a horrible view, but anyway, this is the fracture line. Second phase, if you can see, so there's actually some white formation of bone on either side. This is the callus starting to form, okay? Here you can see more callus has formed, abundance of callus on the medial side here. Okay, and eventually, this is much later, you can see that the cortical surface is actually remodeled and looks somewhat like an original. There's still a little bit of evidence of an old fracture here, but this is generally what you look for in follow-up of a patient. Okay, so if a patient has a fracture here on day 1, and 6 months later, I look at the X-ray and it looks like this, then it's not healing too well. That means he's going into a non-union or a delayed union or some problem with his healing. Okay, if he follows the pattern and he's healing pretty well, then you don't need to worry. So generally it's on follow-up. It's not just acute stage where you need to be able to identify fractures, but on the follow-up as well, you have to know when is it considered a non-union, when is it considered a delayed union, and when do you need to intervene basically to help the fracture to unite. Okay, does anyone know the difference between a non-union and a delayed union by any chance? It's just one last question.
I asked them a lot of questions.
Too much,
It's okay. Hey, Roshan, I just want to say, I think you should open your slides in a new window, and then you
Okay.
press present. Now
I
I
did.
can now I can see your Facebook, your
Share.
no, I mean not your Facebook, but on top of that, your icon.
Oh,
Okay.
okay.
So W say timing.
Okay. What do you mean by
Timing.
timing?
Timing
Serenity.
as in for your non-unit, the differentiation between
Yeah.
is a timing. And then
Yes. Okay. Of course.
CC says callus
Callus
formation.
formation. Yeah. Okay. Yeah. Anyway, this one is pretty much like if you're studying orthopedics or if you're just doing the orthopedic posting, you tend to remember it. Or if you're orthopedic surgeon, you have no choice. But generally what it means is if you have a delayed union, yeah, something like that. Someone is almost there. No longer feel pain, correct? Yeah, so basically the fracture should unite in a specified time. Okay, that's the general rule. Any fracture will unite and it has given a certain time for it to unite. Okay, if it does not unite in that specific time, it's considered a delayed union. All right. If it doesn't unite in a specific time and the evidence that the healing has stopped based on the fact that the x-rays look exactly the same, then it's considered a non-union. Okay. So the difference mainly in delayed union and non-union is if a patient has a delayed union, you can actually wait. It's just that the healing is slower. So for whatever reason, whether the patient is malnourished or is a smoker or, you know, there are other medical conditions delaying his healing, it's considered a delayed union. But what you will notice is there is evidence of callus formation. There is evidence of healing happening just slower than normal. In non-union, the process of healing itself has stopped and it will not start again unless you intervene somehow. So that's the main difference between a non-union and a delayed union.
Why does non-union happen?
Yeah, so non-union can happen for two reasons. One is, okay, when you treat a fracture, you need to immobilize it generally. You bring the two fracture ends together and you hold it in place. Okay, if the holding is inadequate, there's too much mobility in that place, you can get a non-union. Okay, so that means the two fragments are together, but it's not held steady. It's still there's some motion going on. It will end up in a non-union. They call it a hypertrophic type. The second is if the factors that cause healing, like the bone condition, the blood supply, the soft tissue coverage to that area is poor. Sometimes you can get an atrophic type of non-union where the process just stops. The bone ends just cannot unite no matter what. You know, so there are generally a few types.
So no article has, how long does a fracture take to heal in the upper and lower limb for adult and children? I think you mentioned that, but
yeah,
let's mention it again.
Sure, no problem. Upper limbs generally, this is just a general rule. Upper limb 6 weeks for adults and lower limb about 3 months for adults. Yeah, so 6 weeks in the upper limb, 12 weeks in the lower limb. In a child, you half that amount. Okay, so you're looking at 3 weeks in the upper limb and about 6 weeks in the lower limb. Okay, so children heal a lot faster, but again, we are looking at the age of the child. Okay, so a younger child, the healing is faster. Okay, if you consider a 2-year-old compared to a 12-year-old, the healing is different. The healing in a 2-year-old is much faster. Even 2 to 3 weeks, they heal upper limb fractures. Maybe 12, 13 years old, you wait a little longer, 3 to 4 weeks. Okay, so the general rule is that 6, 12 for adults and half of that for children. Okay.
Okay, any more questions? That is the last slide, so we will take a few questions from you guys.
Oh yeah,
I'm so sorry about the Facebook. It's difficult for me to watch both sides, but we have a lot of response. Yeah.
Okay.
So
this was the conclusion. Did I finish this? Oh, okay.
Oh yeah, sorry, you haven't finished.
Okay.
Oh, I'm so sorry.
Integral part of diagnosis and management. No, I'm just reading it off anyway. An accurate interpretation of X-ray films aids significantly. Firstly, know the anatomy and the pathophysiology of healing before you start reading X-rays. Be systematic. Again, location, pattern, alignment, and don't forget soft tissue. Certain conditions may require special views, different type of interpretation. And of course, more advanced modalities are available, but of course, you should never forget the art of actually reading an X-ray. Okay, any questions? I'll be more than
Okay,
happy.
any questions? So sorry. Okay, okay, there slowly, slowly, yeah.
So, doctor, is it necessary to hear crepitus upon movement of a complete fracture? If you do that, you're quite painful for the patient. I wouldn't want to start squeezing them until I feel crepitus and whatnot. Okay, clinical examination for a patient doesn't mean you feel crepitus. If you can elicit tenderness, you just press at the area that is painful. Just say patient has a distal radius fracture. You don't have to press until you feel crepitus coming on or something crickling and crackling there. Okay, you just feel if there's tenderness, there's swelling around that area, that is highly likely it's a fracture. Don't wait for the crepitus. It's not a rule for that.
Do we use AO classification to describe fracture?
Yes, if you're doing a master's in orthopedics, yes.
Stu Zuiling asked that.
Yes. AO is a very comprehensive way of classifying fractures, very advanced as well. But for surgeons who are, those who are contemplating doing orthopedic surgery, yes, knowing the AO classification is very, very important and very useful as well, because it gives you management-wise the patterns, and they've even come up with a pediatric version of it as well, actually.
Okay, Serena asked, what do you do for a non-union? How long do you wait?
Yeah. So if you find that there's no more healing going on, okay, so like 3 successive X-rays or what, it looks exactly the same. It's probably a non-union already. Okay, and depending on which part of the bone and which type of non-union. Okay, so if the non-union occurs because there's too much movement at the fracture site, you have to hold it stronger. Okay, and put maybe a stronger fixation, a more rigid internal fixation or external fixation, whichever. If you notice that it's an atrophic non-union, that means the bone healing has stopped. It's just dying down. There's no more biology going on in that area. Then the patient needs stimulation of that. So something like a bone graft would help. Yeah. So depending on the type of non-union, that's how you sort of manage them. That's just a general.
Sorry, we have a question from Facebook. Simon, we asked, can you explain more about intramedullary nailing and DCP? Thank you.
Okay, that was not part of this at all, but yeah. What would you like to know? Okay, both are methods of internal fixation of long bones. All right, intramedullary nailing is where you put the nail in the intramedullary canal, whereas plating is you placing the plate on the outer part of the cortex of the bone. Okay, both have its advantage and disadvantage. Commonly in lower limb fractures, intramedullary nail is the preferred choice because it's what they call a load sharing device, meaning which you can start putting weight a little earlier on your leg. If you start walking with crutches and whatnot, you can start weight bearing a little earlier if you use an intramedullary device as compared to a plating. Yeah, can get a lot more technical than that, but
okay. I think that one we have to go for another session.
Yeah.
Is there a general timing rule for removing cast?
Yes, once the fracture has healed.
Okay. And then
so based on the X-ray findings and based on the timing that you notice that it's done, like say for a child, 3 weeks post-trauma, the X-ray looks good, then you can remove the cast. Yeah. Problem with casting, of course, is stiffness. So you don't keep it for too long. Any role for ultrasound and diagnosis fractures? Pretty much not so. At this moment of time, there's no real reason. I reserve ultrasound mainly for soft tissue injuries. I think fractures, they're fairly more obvious. CT scans would be more useful in identifying X-rays, identifying fractures as compared to ultrasound. So CT scan is good. If you don't have that, and they have an OT facility, you can actually do stress views, which means if you cannot see the X-ray, you take the patient into OT, put them to sleep, and you stress the area and see if the fracture opens up. So you don't do it when they're awake, you put them to sleep.
Okay. Yeah. How long do we expect to see callus after bone grafting?
Okay, that's a good question. Okay, depending on the type of material you use for bone graft and what is the indication, but you should, when you put a bone graft, it actually tends to look a bit like, you seeded a plant actually for it to grow. So you would expect it to start showing within the first 4 to 6 weeks, I would say. You should see some change within 6 weeks at least.
How to decide when to put back slab or casting? I think that is a bit too wide a
Not really, not really.
general
Okay,
a
so
question?
yeah, generally, the general question, so the general answer would be most fractures are treated with a cast, but you always have some amount of soft tissue swelling. If there's too much of swelling, I will put them on the back slab first, let the swelling settle, and then convert to a cast maybe in a week or two. That's
Oh,
the simple way of
May
doing it. Yeah, but there are other,
you
I mean,
can
there are other
watch
reasons for using it as well.
you can watch May you can watch the previous lecture by Dr. Roshan. He mentioned this,
Did I?
the trauma one.
I forgot as well.
Yes,
So
yes.
long ago. Okay.
Yes, in YouTube, yes. Duration
Okay.
of
Body
body
split. Yeah, this one very common. Did someone here like stub their toe or something? Okay, toe fractures different. Okay, they generally heal quite well unless it's a big toe. So if it's a little toe or whatnot, generally a maximum of about 2 weeks, I think you can remove it and allow them to weight bear more on the heel. Generally works quite well for toe body splinting. Is full weight bearing allowed once fracture union? 100% yes. Once the fracture is united, patient should be allowed to full weight bear, run, jump, everything.
Okay, good. We have done an hour.
All
and
right,
I
excellent.
think just excellent. The timing is perfect.
Okay.
Everyone were very interactive. I think it was a very good session. Thank you so much, Roshan.
Thanks, Betty. It's my pleasure. It's my pleasure. I hope
Yeah.
it helps somehow. All right.
Yeah,
Thank you so much, everyone.
Okay. Before
One more
you
question.
go,
Thank
just
you.
to say, next week we have a session also. We are bringing in Dr. Lai, who is a consultant psychiatrist, and he's going to talk about how not to let your work kill you. Means how to handle being a doctor. And of course, we will also touch on prevention of suicide and mental health. So I see you guys next week, same time, same
Thanks,
day.
Dr. Betty. See
Yo,
you.
please, Roshan. Bye, Roshan.
Bye. See you.